So as the name suggests, acute pancreatitis is inflammation of the pancreas, and this results due to autodigestion from those activated trypsinogen molecules, turning into trypsin. So here's our model that we talked about before. Just remember that these right here are already activated, and these are appropriately activated in the duodenum, where they should be exerting their effect. But if we have activation prematurely, you can get reactivation, because remember, this trypsin can activate a trypsinogen into it. So you get this positive feedback loop, and over time, this can cause serious damage to your pancreas. It'll cause two types of necrosis, and this is sometimes tested on step 1. It'll cause liquefactive necrosis of the pancreas and fat necrosis of the nearby peripancreatic fat. So what does that mean? Liquefactive necrosis is a type of necrosis in which your cells are digested. And just so we know, necrosis versus apoptosis, I learned it as apoptosis is cellular suicide, where your cell knows it's in trouble, it knows it was infected with something, so it basically starts to shut down in a very organized manner, packages it up, and makes sure it dies in a way that doesn't damage other cells. Necrosis is just it's cell death. It's your cells are dying for whatever reason. There's no rhyme or reason to it. It's not trying to slowly package it up and go through this process. It's usually dying, and it's a pretty it can be a pretty chaotic process. So as you can see here in liquefactive necrosis, dead cells are forming this liquid mass. You'll see this in the pancreas, and you'll also see this in the brain, as because that also have liquefactive necrosis is stereotypic of that region. And so another thing we should talk about is fat necrosis, though. So what happens here is that as the inflammation progresses, you can affect the nearby peripancreatic fat. And then in fat necrosis, you'll have fatty acids and triglycerides getting released from this damaged region now. So that's those it's important to distinguish, both of those types of necrosis. So what causes acute pancreatitis? The most common cause of pancreatitis are gallstones, followed closely by alcohol exposure. You can also have hypercalcemia that causes this, hypertriglyceridemia, an ERCP can cause it, mumps can cause it, and several of the cases are simply idiopathic, where we don't know exactly what's going on or why it's causing it. And there's a lot of other causes. You'll hear like scorpion bites, and I think I have a slide right here. Yeah. So here's a slide of mentioning most of what we talked about. Don't forget autoimmune pancreatitis, trauma. Sometimes they test this. This is more of a step 1 thing, where they want you to know if you're bit by a scorpion or a brown recluse. I'm gonna say it was low yield, but I would actually know the brown recluse specifically. I've seen this tested before, and I've had practice problems on this. Brown recluse spider bite causing acute pancreatitis. They do like that from time to time. What I wanted to do, though, is I specifically put these causes in because I want to talk about why they happen, and just so you have a better sense of what's going on. So in gallstones, what's happening is pretty straightforward. A gallstone, as you remember, the common bile duct meets up with the main pancreatic duct. So if a gallstone makes it all the way down and lodges itself in there, you can have a blockage of your main pancreatic duct. And what'll happen there is that over time, your trypsinogen molecules can get activated and they can cause damage. In alcohol, the mechanism's low yield, but just know that you'll secrete additional pancreatic enzymes here. I'll show that one more time. Basically, it increases your pancreatic enzyme secretion, alcohol does, and then it causes inflammation. You just need to know that it's the second most common cause of pancreatitis. Don't worry about the mechanism. Hypercalcemia, you'll have calcium that can activate your trypsinogen molecules, so that'll cause damage. Hypertriglyceridemia, you can get triglycerides that get broken down into free fatty acids, and these can independently damage your pancreas without needing to activate trypsinogen. In an ERCP, just so you can see what that is, basically, if you ever have a gallstone stuck, you can take a device. A GI doctor can take a device and can try to basically dislodge this gallstone, but in this whole process can cause pancreatitis. So, which is kind of ironic because usually you're doing this in a patient who has pancreatitis and you're trying to help them, but yeah, sometimes the solution causes more of the problem. And just to reiterate with those, what we just talked about, you actually don't need to know the mechanism. I'm just trying to show you it just for your own learning, so you can see why you would actually get pancreatitis. You just need to know that these are causes. And the last one I wanted to just mention is mumps as a classic cause of pancreatitis. This is from our oral cavity lecture, which was a while ago. And I just wanted to remind you that in our mnemonic that I talked about with mumps, that stands for mumps, orchitis, aseptic meningitis, pancreatitis, and then parotitis. Okay, so let's move on to how somebody with acute pancreatitis will actually present and what you can do to find out if they actually have that. So the classic pain pattern is somebody who has epigastric pain radiating to the back, and they will give you this in this question step. So once you hear that, I want you to immediately think pancreatitis. You'll also have somebody with nausea, vomiting, loss of appetite. So think about all that. On laboratory findings, studies, you'll find elevated amylase and lipase. They like to ask which one is more specific, and the answer is lipase because you don't have a salivary lipase. So it's more, lipase is more specific than amylase. You'll often find an elevated white count, which doesn't surprise you because any itis can have an elevated white count. You'll have cholestatic liver function tests, which just means you'll have the liver function tests that are consistent with some sort of obstruction. So if I go here, I talk about this in the upcoming lectures, the hepatobiliary and the liver lecture. But what's happening is that bile is composed of several different compounds, some of these compounds also travel with the bile to escape into the duodenum. So if they go here, the gallbladder will contract, and along with the bile, you'll get alkaline phosphatase, conjugated bilirubin, and GGT. The problem is that if you had like a gallstone per se, let's say, then nothing can flow out here, and it'll instead flow into the bloodstream. So you'll get elevated alkaline phosphatase, elevated GGT, elevated C-bili, and that explains the cholestatic LFTs. That's what that means. And keep in mind, this would only happen if you had gallstones as your cause of pancreatitis. If you had another cause of pancreatitis and bile was still able to flow out the common bile duct into the main pancreatic duct and out into the duodenum, then you wouldn't see cholestatic LFTs, but in gallstone pancreatitis, you would. Some prognostic indicators that you should be aware of is that hypocalcemia and elevated BUN are both poor prognostic indicators. So let's talk about each of those. So in hypocalcemia, why would that happen? So we already know that you can get inflammation of your pancreas. Nearby, you have that peripancreatic fat. And when that peripancreatic fat also gets inflamed, you can get hypocalcemia because these fat molecules love to bind to calcium, and they'll take up all the calcium that's in your bloodstream and they'll bind to it. This is a slide from a previous lecture on Crohn's disease. And as you can see here, the reason you get calcium oxalate stones in your, actually, the reason why you get calcium oxalate stones is because you have a lot of oxalate that enters your bloodstream. This happens because you have a ton of free fatty acids, and these free fatty acids love binding up calcium that allows oxalate to escape. The same thing's happening in acute pancreatitis, where you have a bunch of free fatty acids that end up being released into your bloodstream because of that inflammation. And all those free fatty acids that make it into your bloodstream bind to the free calcium that's in your bloodstream and give you hypocalcemia because the calcium measured won't detect these calciums anymore. So the elevated BUN is a little bit more straightforward. All you need to know is that if you have persistent inflammation like this, you're always, anytime you have inflammation, you're losing intravascular volume. Volume's just kind of leaking out, basically. And whenever volume leaks out like this, and you lose a lot of your volume, less of that uh, intravascular volume will reach your kidneys, and you're going to have an elevated BUN. This is less important for step 1 or level 1, but I do want to mention that there are different criteria that you can use to assess the prognosis of somebody with pancreatitis. Ranson's criteria or the Apache 2 scores. I'm not going to go into each of these scoring systems, but it's worth it to at least look it up if you have a patient with pancreatitis, just to stage them. On examination, there's a couple classic things they want you to know. First off, they want you to know abdominal tenderness, but what's more important are these signs. So there is a couple signs, colon sign and Gray-Turner sign, which I have pictured here. So colon sign on the left is our periumbilical ecchymoses. And I want you to remember colon for umbilicus. And you can see this bruising right here near the belly button. Gray-Turner sign, on the other hand, are flank ecchymoses. So this is on the side or flank. And I want you to remember this by the phrase, you turn to your side. And that should tell you that Gray-Turner's is for side bruising. So how do we diagnose acute pancreatitis? It has a very straightforward diagnostic criteria. You need 2 out of the following, okay? So at least 2 out of these 3. Epigastric pain radiating to the back is number 1. You need an elevated amylase or lipase, and it has to be at least 3 times the upper limit of normal. Or you can have characteristic imaging findings. So as long as you meet any 2 of these 3, you have a diagnosis set. And just to mention, so I talk about characteristic imaging findings. Sorry to go back and forth. Here is a normal pancreas, and you can see this nice demarcation. It's a very small pancreas. But over here, you have a lot of edema, and it looks boggy and unclear. And so that's what you're going to see in a case of acute pancreatitis. How do you treat this? So you treat it by not giving them any food, because it's going to make the problem worse. You should give them IV fluids, like we just talked about. Any inflammatory pathway or disease can ultimately decrease your intravascular volume. So IV fluids can be very helpful in reversing that and making sure somebody still is resuscitated. And you should also give pain control. And I just want to remind you that the old guidelines stated that you shouldn't give morphine because it can change the sphincter of Oddi and cause spasms, but that's hasn't really been as true as it was hypothesized. Just wanted to let you know. So let's go over a practice problem to solidify our diagnosis and treatment for pancreatitis. So let's say we have a 52-year-old male with cholelithiasis, which is gallstones, presents to the ED with severe epigastric pain radiating to the back. On labs, we notice an elevated white count and significantly elevated lipase. We also notice these cholestatic labs that we talked about before of elevated alkaline phosphatase and conjugated bilirubin. And so now, what's the next best step in management for this patient? Would you scan them to evaluate? Would you just observe them? Would you do a right upper quadrant ultrasound? Would you do an exploratory laparotomy? Or would you cry profusely because you forgot how to diagnose pancreatitis? Well, I have more faith than you all, but the first answer is good. This answer is going to be right upper quadrant ultrasound, okay? Let's talk about why that is. The first thing we should rule out is E, because y'all are smarter than that, and I totally trust that you at least knew it wasn't one of these, okay? We know the treatment for pancreatitis is to be NPO to give IV fluids and to do pain control. So we shouldn't assume that we're going to give somebody a surgery right away for this. And we also shouldn't just observe them because there's a little bit more to it than that. Next thing I want to talk about is why A is wrong, because A looks very, very appealing. We just talked about characteristic imaging findings on a CT scan. Well, in this case, we already have 2 out of our 3 findings. We have our severe epigastric pain radiating to the back. That would be number 1. And we have a significantly elevated lipase. That would be number 2. The next thing I want to mention to you all is that this person has a history of gallstones, and they have those cholestatic LFTs, which are very highly suspicious for some sort of gallstone pancreatitis. The best way to view this is to get a right upper quadrant ultrasound to evaluate for gallstones and to see if there may be a component of gallstone pancreatitis playing a role here. It's less about diagnosing it. We've already diagnosed pancreatitis. Now we're trying to find out the cause of the pancreatitis. There are a few local and systemic complications that they do like to test for step 1. So a pancreatic pseudocyst is a collection of pancreatic fluid surrounded by granulation tissue. These usually take a few weeks to form, so at least 4 weeks to form, and they're common in the lesser sac posterior to the stomach. Because these cysts can get very large and stay for quite some time, they may require drainage if it's large enough, because the walls aren't super strong. So what does that look like? So what's happening here is that we have all these digestive juices and liquefactive necrosis going on when you have this inflammation. And if the inflammation continues and you actually have almost like a fistula here forming from the lumen, you can start getting a leakage of fluid, and this can grow into this collection that's surrounded by granulation tissue. And keep in mind, like we talked about before, this can take on the order of weeks sometimes. It's a very slow process. And just so you know what granulation tissue is, it's simply, I would just consider it as a form of connective tissue. It's a mixture of connective tissue here. And here you can see a very large pancreatic pseudocyst right here. And so let's move on to a pancreatic abscess. That's an infection of that pseudocyst. And in these patients, you're going to see a fever and failure to improve in somebody who has recent pancreatitis. And this will require an incision and drainage if it's greater than 6 centimeters or if it's present for more than 6 weeks. So there's like a little 6 and 6 rule for this one. So going back to our pancreatic pseudocyst, this time, what if the pseudocyst gets infected? So if it gets infected and you have a pancreatic abscess, just remember you have to drain it if it's been there for over 6 weeks or if it's greater than 6 centimeters in size. And these aren't hard and fast rules, but on boards I would go with this. That's more of a step 2 thing though, so just keep that in mind. Acute necrotizing pancreatitis is widespread liquefactive and fat necrosis to the pancreatic tissue. And in these cases, you might require antibiotics, but I just want to let you know, antibiotics are technically only required if you have an infection identified on biopsy. This guideline has changed over the past few years, so I don't think they'll test it. And maybe by the time you're watching it, it will have already changed back. So I don't know. But I just wanted to include what the current guidelines state regarding antibiotics in acute necrotizing pancreatitis. So that looks like if you have really bad inflammation all over the place, ultimately this can cause necrosis where your cells all die. And that is not good. Very low yield disease though in general, because it's pretty straightforward. These systemic complications, they only test you it in the context of acute pancreatitis for most of these, but I think they're useful to go over each of these 3 because they're going to be really important later on. And this one's important for pretty much any inpatient rotation you'll ever do in your life. So SIRS, systemic inflammatory response syndrome, This is whole body inflammation. So a lot of people think it's infection, and it could be due to infection, but it could also be due to ischemia, other inflammation, or trauma. So it's an exaggerated immune response to some stressor. And as we just talked about, it can be caused by many different things. And the SIRS criteria is very straightforward. There's 4 categories, and you just need to be 2 or more need to be positive to be SIRS positive. So for temperature, your temperature normally is 37 degrees Celsius. So if you're less than 36 or above 38, you'd get a point. If your respiratory rate's greater than 20, heart rate greater than 90, and then your white count, again, there's a double category. So it's either greater than 12,000 or less than 4,000. So if you have 2 of any of these 4, you'd be SIRS positive. And then the next step, if you have a SIRS positive and you think they're infected, you need to look for a source. So if you ever have SIRS and a suspected source of infection, you'd have sepsis. And that's all you need to know for step 1. Just know that if you ever have sepsis and then you also notice end organ damage, then you have severe sepsis. If you ever have sepsis and you start becoming hypotensive, requiring pressors because fluids aren't working, then you'll have septic shock. But just know SIRS, and this is the complication of pancreatitis specifically, you have all this inflammation. You can even get an exaggerated immune response to that, and you'll ultimately have SIRS. ARDS is a life-threatening fluid accumulation in the alveoli due to damaged epithelium, and it'll cause a classic non-cardiogenic pulmonary edema. So let's talk about both of these concepts. So on the left, we have our alveoli, and we have a pulmonary capillary. And we haven't talked about the lungs, but just note that you're at the very, very distal ends of all your lung sacs. You have these little grape-like clusters called alveoli. And they're wonderful because they are the part that talk directly to your bloodstream and make sure that your O2 and your CO2 are balanced correctly. So what's going to happen is that from the alveoli, you get all breath of fresh air, you breathe it in, and you have all this oxygen coming in. It reaches your alveoli, and it can go straight into your bloodstream. At the same time, these capillaries are able to dump their CO2 straight into your alveoli, and ultimately, you'll exhale that CO2. So what happens in ARDS is that you have this damaged epithelium right here. And what's going to happen is that all the fluid that's within our pulmonary capillaries, it can now see this damaged epithelium and it starts to leak out and into our alveoli. Remember, we just needed our alveoli for that gas exchange, that CO2 and O2 gas exchange. So if you have all of this water here, it's obviously going to have an effect on your breathing and several other factors. So I want to talk about non-cardiogenic versus cardiogenic pulmonary edema and talk about what happens here. So in cardiogenic pulmonary edema, we have our lungs, which the blood goes from the lungs to the heart, back to the body, and ultimately back to the lungs later. So if your heart's not working, let's say you have heart failure, what's going to happen is that we can't get all the blood flowing from our lungs to our heart. So it's going to back up in this region. And as it backs up and the pressures grow, you're going to get cardiogenic pulmonary edema because of that back pressure. And you can measure this if you take the pulmonary capillary wedge pressure, which is just our left atrial pressure, you'll notice that it's a lot larger. So if your heart's not pumping well, that would mean more fluid would stay in the heart and you'll have an elevated PCWP. In ARDS, it's a form of non-cardiogenic pulmonary edema. So in this case, we're getting fluid in our lungs, but it's not because our heart, it's not a cardiogenic pulmonary edema. It's simply because we have damaged epithelium within our lungs that's causing that fluid accumulation. So again, fully functional heart, normal pulmonary capillary wedge pressure. Here's a picture of ARDS. This is what they're going to show you a picture like this if they give you ARDS, and it's just going to look atrocious. You could see all the inflammation all over. And ARDS is extremely dangerous with almost a 50% mortality rate. Moving on to the next one, DIC, so disseminated intravascular coagulation, is also a very dangerous disease. So this is what's referred to as a consumptive coagulopathy. And it's called consumptive because it's going to end up consuming platelets, coagulation factors, clot inhibitors, among other things. And you're going to see a combination of bleeding and thrombosis in this condition. So in DIC, what's exactly happening? We just talked about how there's consumption of clotting factors, inhibitors, and platelets, which is why it gets its name of a consumptive coagulopathy. And it can be caused by several different conditions, but most of which are very life-threatening. And in this case, we're talking about pancreatitis. So let's go over the clotting cascade, which we all know and love, and talk about DIC's pathogenesis. So here we have the intrinsic pathway and the extrinsic pathway. And you can see here that their common denominator is factor 10. And ultimately, their goal is to turn factor 10 into factor 10A. Once that's done, it goes through another series of steps. And what I want you to know is that ultimately fibrinogen gets converted into a fibrin clot. So everything you've seen here, the whole point of this cascade and this cascade is just to form a nice stable fibrin clot. And fibrin kind of looks like a fishnet. It's a very nice mesh. So I always think of it as the fibrin fishnet. And that's all this clotting cascade does. It's really designed to give you this nice stable fibrin fishnet mesh. Let's take a step back and see what happens in DIC. So in DIC, you have systemic release of tissue factor, which is right here, this TF. And keep in mind that tissue damage can release tissue factor. So oftentimes a lot of these causes have so much widespread tissue damage that that's what's releasing all this crazy amounts of tissue factor. That tissue factor can start activating the clotting cascade. So factor 10 is turning to 10A, and ultimately, as we just talked about, you're going to get more fibrin fishnet clots coming through if you're having more of this factor 10A. Now, over time, a few things will happen. So the first thing that's going to happen is that clotting factors and fibrinogen are depleted due to all these fibrin clots forming. So you can see that thrombin's been working its butt off trying to move along this cascade. Fibrinogen's been working hard, but at some point there's going to be so many stable fibrin clots that you're going to run out of the materials used to make them. At some point, you're going to have so many fibrin clots that you're going to run out of the materials to make them. While this is all going on, it's not like our body just lets you make a bunch of fibrin clots and doesn't have a counter-regulatory mechanism, right? So we actually have a lot of clotting factor inhibitors that will break down fibrin clots to make sure that we're not having too much of a hypercoagulable state. Again, though, there's so many stable fibrin clots that even these guys struggle sometimes. Oh, another thing I wanted to mention before I move on is that all of these inhibitors, if they're degrading fibrin clots, they break them down into what's called fibrin degradation products, one of which being D-dimer, which you may have heard of in the past. But again, over time, if all these clotting factor inhibitors are working hard and there's just too many stable fibrin clots, you're going to run out of these inhibitors one day. Last thing I want to mention is that platelets become trapped in these fibrin clots. And those can, if those are trapped, then you also lose platelets and you become thrombocytopenic. I just came back to this slide really quickly because I wanted to point out something that's happening here. So what's happening here? A, we're losing all of our clotting factors, right? So if you lose your clotting factors and we're losing platelets, we're more likely to bleed. Another thing that's happening, though, is that we're also losing a lot of clotting factor inhibitors. which makes us susceptible to clotting. So it's this weird condition by which we are actually more prone to clotting and more prone to bleeding at the same time. So for the symptoms, you're just going to have clotting symptoms like ischemia, thrombosis, or end organ damage. And you also may have bleeding symptoms. And so this is, you'll classically see somebody who's just bleeding from all of their lines and you can't get the bleeding to stop. That's what questions them where you should strongly consider DIC. On laboratory findings, you're going to find an elevated PT or PTT, decreased fibrinogen, elevated D-dimer, and a decreased platelet count. So going through each of these four, elevated PT or PTT, I just want to remind you that PT is a measure of your extrinsic pathway. And I remember this by the mnemonic that you play tennis. You play tennis outside, so that's why the extrinsic pathway measures PT, excuse me. And if you have a damage to tissue factor here, then you can get an extrinsic pathway deficit. PTT measures the intrinsic pathway, which is located up here. And my mnemonic for this is that you want to play table tennis or ping pong indoors. And I didn't do a great job of showing this, but when you have too much thrombin, this can activate other clotting factors. And if these are overactivated and overworked, you'll start to become depleted in them, and you'll get an intrinsic pathway deficit and an elevated PTT. Fibrinogen is very straightforward. If we're making all of these stable fibrin clots, we're losing a lot of fibrinogen. So you can see right here, fibrinogen is very low because we've had to use so much of it to make these stable fibrin clots. D-dimer also makes sense. We talked about how our clotting factor inhibitors break down fibrin into these fibrin degradation products, so you'll get a lot of D-dimer in patients who have DIC. And then decreased platelet count, again, very straightforward. These platelets get stuck in the clot and you get thrombocytopenia. To treat this, remember there's several causes of DIC. It's not its own entity, it's like a symptom of another condition. So the real important thing is to treat the other condition. And in the meantime, you still might have to give transfusions, factor replacements, or anticoagulation depending on their symptoms. Besides DIC, ARDS, and SIRS, I just wanted to mention that you can also have hemorrhage, shock, multi-organ failure in patients with severe acute pancreatitis. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.